Okay, hi, welcome everyone. Okay, so I'm the NEET Core Team Leader, Astron Institute of International Studies, Gurgaon. So today we have webinar on bundle care for prevention of healthcare associations infections. But before starting the webinar, I just want to introduce my organization to you. Okay, so we are 18 years old company focused on planning, designing, also doing quality and accreditations for the hospital by doing NABH and JCI. We are offering 50 plus certificate and diploma programs for nurses and paramedical technicians, adopting a blended approach with major focus on practical learning through on job training. Right now, more than 10,000 plus nurses are certified and well placed at national and global level in reputed organization with the NABIT, that is ISO 17024. And also proud to tell you that now we are also training partner with Skill India. So now I would like to introduce our expertise, Dr. Pushpa K. Nirwan. She has 16 years of extensive experience in microbiology and infection controller nurse and MSc microbiology from University of Madras and PhD in medical microbiology from Hamdard Institute of Medical Science and Research. Zamia Hamdard, New Delhi. She joined RMS Hospitals in year 2008 and has been working in the field of infection controller and microbiology research since then. Dr. Pushpa has been an active auditor for NABH, NABL, JCI Green OTs. She has been awarded with first prize in ARC for poster title Mutations in PHOPQ.
Good afternoon, everyone. I first of all thank Astron for giving me this opportunity to talk to you about a very important topic, that is bundled care for prevention of healthcare associated infections. So we will start with a very short story without wasting much time. In 1847, you all must have heard about Professor Dr. Ignaz Philipp Semmelweis. He was a physician and a scientist and a very well-known figure in the field of infection control. His primary work was in a hospital, being a physician, and he was in charge of the maternity ward. So during his career, he has seen the infections in the mothers of puerperal sepsis, and he proposed a theory over there that health workers could be the transmitters of infection. Now, his theory was not being accepted very well during those days, and but the intervention that he did was that he created an atmosphere of washing hands before going to deliveries for healthcare workers, and the solution was chlorinated lime. So this was his theory that transmission is happening through contaminated hands. Now, in 1890, when Robert Koch came into the picture, he was again a very big scientist, and he created some postulates due to which it was proved that the germ theory of disease exists and transmission from one person to other is possible. And it was then that Dr. Ignaz Philipp Semmelweis received the recognition as father of hand hygiene. So, but the irony was it was almost 20 years since his death that he got this recognition. So this is one of the picture from the past where he is using chlorinated lime solution for washing hands. So the cardinal rule in healthcare is do no harm. So what are the opportunities when we have, when we know that we can harm a patient? It is due to invasive procedures. We receive lots of immunocompromised patients in the hospital. The hospital environment itself has so many bugs. There are increased antimicrobial resistance. We have a very less choice of drugs left with us. And finally, the errors that we do intentionally during our healthcare. The precarious situation today has two important problems. One of them is healthcare associated infections, which has these four types: the central line associated bloodstream infection, catheter associated urinary tract infection, ventilator associated pneumonia, surgical site infection. And we see that every year more than 24% of patients affected by healthcare associated sepsis die due to any of these infections. The other bigger problem is the antimicrobial resistance. We all know about, we have heard these bugs, VRE, MRSA, So those who are in nursing practice hear about these names in their day-to-day practices. These are vancomycin-resistant enterococcus, methicillin-resistant Staph aureus, carbapenem-resistant Acinetobacter baumannii, so on and so forth. So why are we bothered about antimicrobial resistance is that we have the mortality increased about 2 to 3 times when we have infections with the MDR bugs. And in ICU patients, about 52.3 patients die each year with these infections. So this is all what statistics say. Now the problem about HAIs, because our topic is more around the healthcare associated infections today. So these infections kill about 1 million people, which is much more than HIV or AIDS, cancer, and road traffic accidents. So out of every 100 patients, 7 in the high income and 15 in the low and middle income countries acquire at least one HAI during their hospital stay. So it shows that this problem is of a major concern to us. And on top of it, it is associated with 10% mortality. And we have also seen in the previous slide that about half of all sepsis cases with organ dysfunction, which are treated in ICU, acquire healthcare associated infections. Then what is the solution? Because we have the problem as a multimodal, multifaceted, the solution has to be multi-pronged. So the solution says that 70% of these HAIs for which we are worried can be prevented through good IPC practices, which include allocating human resources, providing infection control supplies, and infrastructure. So a good IPC program provides safety for all patients, healthcare workers, as well as visitors. We have all heard of chain of infection. It starts with portal of entry. It enters into a susceptible host, becomes an infectious agent, causes infection, and stays as a reservoir in the patient's body. Then it comes out through the portal of exit, which is an important part of transmission. So if we put a break in this chain at this particular point, the transmission of infections from one patient to another can be prevented. So even WHO has given that multimodal strategies always work better when you try to achieve good results in infection prevention and control. So now we come to our topic, that is care bundle. So as per the definition given by CDC, it is care bundles are a set of evidence-based practices that when applied collectively and reliably have been shown to improve patient outcomes. Now these words collectively and reliably are very important here. Why bundled care is needed? Bundled care is needed because a collective approach is always better than an individual exercise. If you have increased bundle compliance, it gives you better quality of patient care. A culture of positivity and a reliable care is created in the environment. It also promotes teamwork because one after the other in the shift, we have to follow the bundled care. It also gives an accountability because we are accountable for the work that we are doing for the patient and we are documenting it. So you can anytime get caught if you have not provided the desired care. How to create the bundled approach? So the first and foremost thing is it should be very simple. If we create complicated bundles, it is not easy to implement them and their effectiveness decreases. So we have to create reliable and consistent care systems which are simple, clear, and concise because a lot of varied population of nurses have to follow these bundles. Now they are formulated based on the local setting. You cannot follow the bundle practices that are that are implemented in US because Indian environment is different. Indian teams are different. So having different healthcare settings and different healthcare teams, we have to formulate bundles which are more congenial to our settings and teams. It has to have a multidisciplinary involvement because Bundles are not something which only nurses have to take care. Bundles have to have uh, implemented by the doctors also, by physiotherapists. So anybody who is at the point of care has to take up the bundled approach. So there should be multidisciplinary involvement during formulating the bundles as well, because they have to be implemented better. So today we are going to discuss about bundle prevention for these 4 infections: COTY, CLABSI, VAP and SSI. So bundle is basically a very basic approach. It is not something advanced. It is not an advanced care. It is all the basic techniques that are bundled together to get better results. Yet it is very important. So let's start with catheter-associated urinary tract infections. So why bundled care is important in COTY is that urinary tract infections are one of the most important of HAIs. And as per CDC, almost 12 to 16 patients who are catheterized during their hospital stay get COTY. Approximately 75% of UTIs acquired in the hospital are associated with a urinary catheter. And the good thing is 70% of them are preventable. So let's focus about preventing those 70%. Now, the greatest risk factor is prolonged use of catheter. So being in healthcare practice, we all know that the longer the catheter is present in patient's body, the more susceptible the person becomes to COTY. So bacteria and yeast travel easily through the catheter and they result in developing COTY. Risk of acquiring a COTY on a daily basis increases by about 3 to 7%. So this shows that how deadly it is. Now, the sources of pathogens. There are some extraluminal sources which are not in the luminar, from the luminar cavity, and there are some intraluminal sources also. So, in the extraluminal sources, at the time of insertion, it is easy to enter. And in the later stages, by capillary action, the organisms may get the access into the catheter. For intraluminal, any breakage in the closed drainage or any contamination of collection bag urine may cause COTY. The sources may be endogenous or exogenous. So endogenous sources are organisms that are present on the body of the patient, like meatal, rectum. So any colonizer that is present in the perineal area of the patient may get access during insertion or later during maintenance. Exogenous means anything that is coming through the environment. So that may be contaminated hands of healthcare workers. Likely pathogens for COTY include Enterococcus, Klebsiella pneumoniae, Staphylococcus aureus, Proteus mirabilis, Pseudomonas aeruginosa, and group B Streptococcus. The most important thing before coming to the bundled care is indications for catheterization. Now, we must know when the catheterization is appropriate and when do we call it as inappropriate. Appropriate catheterization is condition when acute urinary retention or bladder outlet obstruction exists in a patient. When there is a need for accurate measurement of urinary output in case of critically ill patients. They are also used as a perioperative for surgical procedures. So in case of urologic surgeries, gynae surgeries, when there is anticipated prolonged duration of surgery, like liver transplant cases, neuro cases, when it is anticipated to receive large volume of infusions or diuretics during surgery, even then we prefer catheterization. And when there is a need for intraoperative monitoring of urinary output. So the next is to assist in healing of open sacral or perineal wounds in incontinent patients. It also adds to patients required prolonged immobilization. So anybody with spine surgery or neuro procedures, they have to be immobilized for a longer period. That is why catheterization is justified in such cases to improve comfort for end-of-life care if needed. Now, when is it inappropriate? It is not a substitute for incontinence. So it is not a substitute for nursing care. So whenever we can go for an alternate like condom catheter, we must avoid indwelling catheterization. It is a means of obtaining urine it is not a means for obtaining urine for culture or diagnostic tests. In such cases, it is inappropriate. For any prolonged post-operative duration, if we provide catheter, it is inappropriate. So when the patient can easily void or we can use bedpan, we must avoid catheterization. Now we come to urinary catheter bundle. So the important three things in the catheter bundle is avoid use of urinary catheters by considering alternate measures for urine collection. So as we discussed earlier, if we have any alternate, we should not use the urinary catheterization. So first point is the need for catheterization there for patient or not? So that is the assessment for need for catheterization. Use an aseptic technique for insertion and proper maintenance after insertion. So insertion and maintenance are very important components of a urinary catheter bundle. So following evidence-based guidelines. So we normally recommend CDC, ITSA, EPIC, such bodies for formulating the guidelines and the bundled care. Then we come to the maintenance part. Maintenance includes daily assessment of the presence and need for indwelling catheter. So anytime during the catheterization days, we feel that the catheter is not required. We have to raise a query that please remove the catheter. Now the indications for urinary catheterization we have already seen in the earlier slide. So the most important part during maintenance of catheters is providing perineal wound care. So perineal care, it varies from organizations to organizations. Some people use betadine, some people use soap and water. So it has to be done in every shift. That is more important. So these bundles, in case of resource limited settings, when they are accompanied by a multimodal approach of hand hygiene and healthcare worker education, along with feedback of catheter use and COTI rates, they prove to be successful. These are some of the pictures where we have shown aseptic insertion, proper maintenance, catheter required daily assessment. Now, the next bundle is central line associated bloodstream infection. Again, why is it important? So in India, the International Nosocomial Infection Control Consortium, which is INIC, which works for the developing countries, has reported CLABSI incidence of about 4.11 per 1,000 central line days. Whereas the regional studies from India have given the rates as 2.3 to up to 13.8 per 1,000 central line days. The mortality associated with CLABSI is about 45 to 70%, and average increase in length of stay is about 3 days. Coming to the likely pathogens, again we have more of gram-negative, and in gram-positive we have coagulase-negative Staphylococcus, Staph aureus. Staph aureus is sometimes MRSA also, and Enterococcus faecium. This picture shows different access sites in the body for central catheterization. So we can see the internal jugular vein, we can see the subclavian vein, the PICC line, the femoral vein. So all these are the access ports for central line insertion. Now what the reference literature says is, within 7 days of central catheter placement, the bacteria start to migrate from the surface along the catheter to the intravascular cavity. So whenever a catheter is kept for prolonged days, it is a risk for the patient. So these are some of the central lines where we have non-tunneled, which are percutaneously inserted and which have high chances of developing infection. Then pulmonary artery catheters, which are inserted through an introducer, central vein, either subclavian, internal jugular, or femoral. They may develop CLABSI. Then peripherally inserted central line catheters, which are also known as PICC lines. They are inserted into basilic, cephalic, or brachial veins, And the picture which we have seen in the earlier slide has shown uh, these catheters very well. So PICC line have a lower rate of infection than tunneled ones. Tunneled catheters are which are implanted in subclavian or internal jugular or femoral. And there is a cuff which inhibits the migration of organisms inside. So they have a lower infection rate. Then totally implantable catheters, which are tunneled beneath the skin and have subcutaneous port accessed with a needle. So they are also tunneled into subclavian and internal jugular, and they have lower risk of CLABSI development. Umbilical catheter in case of neonates, which are inserted into either umbilical vein or umbilical arteries. So the use of central lines is majorly done for critical care patients and also in other settings like dialysis or intraoperatively or chemo patients likewise. So there's a difference between CRBSI or CLABSI. So I just wanted to introduce it to you people. CRBSI is catheter-related bloodstream infection, and this term was given by ITSA. The definition says that isolation of the same pathogen from a quantitative blood culture drawn through the central line or peripheral vein with the single bacterial colony count at least threefold higher in the sample. So this definition particularly says that you should have more than 15 colony forming units, and the sample which you have taken from central line and peripheral line should have more than 2 hours positivity. Central should come 2 hours positive earlier to the peripheral sample. So that is how a CRBSI is defined. Whereas CLABSI is just when the organism is isolated from a central line after 48 hours of insertion. So this is how they both vary. Of course, with this kind of definition, CLABSI has higher prevalence because any culture that is positive from the central line will be considered a CLABSI, and after further investigation only it can be ruled out. Central line care bundle. So there are two bundles, insertion as well as maintenance in case of central line. Insertion bundle comprises of maximal sterile barrier precautions, which means that the inserter as well as the operator have to wear the maximal sterile precautions, which include surgical masks, surgical gloves, gown, sterile drape. Sterile drape is for patient. Skin cleaning with alcohol-based chlorhexidine. So this is for skin preparation before inserting the line. Avoidance of the femoral vein. So always subclavian is preferred over all the other lines. If it is difficult to access subclavian, then we can go for jugular, and the third preference is femoral. So dedicated staff, yes, central line insertion has to be done by dedicated people, either by doctors or trained nursing staff. They should be competent enough, they should be trained, and they should have regular assessments. Then the standardized insertion packs. Packs include the gauze or other material which are sterilized. We have to check their sterility also before using them. Availability of insertion guidelines. So the hospitals must be having their guidelines based on which the insertions are happening. Use of ultrasound guided insertion for internal jugular lines. So for such lines, we also go for ultrasound guided insertion. The maintenance bundle includes first point, and the most important is daily review of central line necessity. So whenever you feel that the patient does not need this line, it goes for devices that when the necessity is not there, we have to remove the line. The longer the line stays in patient's body, the more they are prone to develop infections. Prompt removal of unnecessary lines, disinfection prior to manipulation of the line. So this is what we call as scrub the hub. So whenever we have to inject into the line, or we have to take samples, or we have to manipulate them, we have to scrub the hub. Then daily chlorhexidine washes in ICU, and we have to disinfect hubs, boards, connectors, etc. We have to change dressing. Dressings may be of two types, transparent or gauze, and they have to be changed in appropriate timings as defined by the organization. Administration sets should be replaced within 96 hours or immediately if used for blood products or lipids. We have to ensure appropriate nurse to patient ratio in ICU, which is 1:2 or 1:1, depending upon the severity of illness of patients. So these care bundles need to be integrated with hand hygiene, clinician and nurse education, performance of surveillance, and feedback of CLABSI rates to measure effectiveness of bundle. So these are some of the representative picks and the process flow. First, we have to do hand hygiene. We have to take maximal barrier precautions. We have to have full body drape for the patient. We have to review. Then comes the maintenance, review the line necessity, optimal catheter site selection, and maintenance, scrub the hub. This is care of site, how you have to scrub the hub. So take the solution and wipe the hub and let it dry and then access the port. Maintenance of dressings. In case of transparent dressings, usually we say that it can be 7 days. We also have chlorhexidine impregnated dressings in which chlorhexidine keeps on releasing gradually, maintaining the killing the germs that are present nearby the site. And the securement of ports. So ports are always kept on a sterile sheet and it is a very important part of maintaining the dressings. So that's all about central line bundle. Then we have ventilator associated pneumonia. Ventilator associated pneumonia accounts for about 7 to 32% of healthcare associated infections. In US hospitals, it is 5 to 10 infections per 1,000 admissions, whereas in developing countries, it is 10 to 52.7 per 1,000 ventilator days. The mortality which is attributable to VAP lies from 0 to 50%. Increased ICU length of stays due to VAP is from 4 to 13 days. And the incremental cost which comes to the patient is about $5,000 to $20,000. Now the source of VAP pathogens. So VAP pathogens may be from oropharyngeal colonization, so that is endogenous source for the patient, gastric colonization, or from the external sources like aerosols from contaminated ambient air, contaminated respiratory instruments that we are using for mechanical ventilation or any other intervention, then contaminated hands and apparels of healthcare workers. So these all serve as pathogens for causing VAP. The likely pathogens that we isolate from ET secretions or BAL are Pseudomonas aeruginosa, E. coli, Klebsiella pneumoniae, Acinetobacter, Staphylococcus aureus, etc. There are some unusual gram negatives also, which I have not listed here, which includes Citrobacter, Burkholderia, Stenotrophomonas, etc. etc. So coming to the ventilator care bundle, there are few points like head of bed elevation between 30 to 45 degrees, daily sedation interruption, which is also called weaning exercise. So we have to assess that. We need to see whether the patient is able to breathe on his own. Then daily assessment of readiness to wean. Daily oral care with chlorhexidine. So chlorhexidine care varies from, you can set the frequency, it may be 2 hourly, it may be 4 hourly, but the more it is given to the patient, the better it is. Prophylaxis for peptic ulcer disease and prophylaxis for deep venous thrombosis. So DVT and PUD are very important prophylaxis which have to be given to ventilator patients. Implemented together with standard precautions. So again, like all other bundles, they also have to be implemented along with the standard precautions as well as adequate maintenance of equipment and devices. Now, additional components of VAP bundle. So apart from the 5 listed above, we have utilization of endotracheal tubes with subglottic secretion drainage for patients who are ventilated for longer than 24 hours. and initiation of safe enteral nutrition within 24 to 48 hours of ICU admission. Now, these are some of the images for VAP care bundle: DVT prophylaxis, peptic ulcer prophylaxis, daily sedation vacation, and head of bed elevation. Coming to the last bundle, that is surgical site infection bundle. So surgical site infections have a reported incidence rate of about 2 to 20%. There is a 2 to 11 fold increase in the risk of mortality with 75% of SSI associated deaths. In India, the SSI rate lies between 2.5% to 41.9%. And the good thing is 50% of all SSIs are preventable. Coming to the sources of pathogens, again, for surgical site infections, we have endogenous sources as well as exogenous sources. First, seeing the endogenous sources, we have bacteria present on or in the patient. So, the normal flora of the patient sometimes migrates to the surgical site and causes infection. And there are some pathogenic bacteria which may be introduced through patient's skin during surgery, which may lead to infection. The exogenous sources are the healthcare workers and the instruments that are used for surgery. So people shed about 4,000 to 10,000 particles per minute. So this is why in OT we have to maintain the sterile practices. We have to maintain sterility in the field, OT field, the OT sterile field, where the surgery is actually taking place. Then surgical personnel have to maintain all the precautions: air, OT traffic, any interruption during surgery, the frequency of interruptions during surgery, everything contributes to development of SSI. HEPA filtration, that is again a component of filtering the air, and surgical instruments are one among them. Likely pathogens. So, in case of SSIs, gram-negative enterobacterials contribute about 61% than gram-positive ones. The important organisms isolated from pus from the surgical site are E. coli, Enterococcus faecium, Morganella morgani, Staph aureus, which is sometimes methicillin resistant, Pseudomonas aeruginosa, and very rarely yeasts. Surgical site care bundle includes 3 different parts. Pre-operative care. So in pre-operative, we have administration of parenteral antibiotic prophylaxis. This should be administered within 60 minutes prior to incision, because we have to have appropriate ratio for for the antibiotic in patient serum, so that when the incision is taking place, we are able to prevent any introduction of pathogens in the body. Redosing is recommended in case of prolonged procedures and in patients with major loss. So this blood loss is about 1500 ml during a surgery. And redosing normally is done every 4 hours, and it is also calculated as per the half-life which is introduced. Patient should be washed with soap or an antiseptic agent within a night prior to surgery. This is also known as antimicrobial bath, which should be given prior night or early morning before surgery. So this is just a measure to decrease the skin colonizers from patient's body. Avoid hair removal. So hair removal is only done when required through clippers, and shaving is prohibited. Intraoperative. So when the patient is actually in the OT and on the OT table, all these precautions are taken care. We have to use alcohol-based skin disinfectant for skin preparation in the OR. We have to maintain intraoperative glycemic control for the patient. We have to maintain normothermia of the patient, and we have to administer increased fraction of inspired oxygen during surgery and after extubation. All this has to be integrated with hand hygiene, sterilization of surgical equipment, use of appropriate appropriate surgical attire, and staff education and feedback. Now, the final component of surgical site bundle is post-operative, which is basically on nurses' part. And this includes discontinuation of surgical prophylactic antibiotics within 24 hours. In cardiac cases, we have 48 hours time. Observe the surgical site for any indication of infection like pain, tenderness, swelling, heat, or anything. We have to inspect the wound site after performing proper hand hygiene or prior to any dressing change. We have to perform hand hygiene. Aseptic technique followed for wound inspection or dressing change, and every closer incisions should be protected with sterile dressing for about 48 hours of surgery. External drain placement away from dustbins or Eurobags. So we have to maintain that the drains that are coming through the surgical site should not touch anything that is contaminated in the vicinity of the patient. Wound care education provided to patient has to be that avoid touching of dressing. So neither patient nor the caretaker has to handle the dressing. So these are the examples of, in the middle picture, we can see the OT sterile field. So anybody who is entering this sterile field has to maintain the sterility and wear appropriate PPE. All the other, in the pre-operative scenario, we have hand scrubbing, hair removal by clipper, skin preparation, and in the post-operative, we have sterile dressings. So the dressings where asepsis has to be maintained. These are some general considerations that bundles are not silver bullet solutions for ruling out all infection risks. But when they are applied in a target group of patients, they are delivered as a part of single process of care. So bundle care given appropriately always brings good results. We have to also ensure that care bundles are concise, simple, and prescriptive. There has to be multidisciplinary involvement. Only nurses cannot prevent all the infections, because anybody who is coming in the point of care has to follow these bundles. Identify members of healthcare team. So the members of healthcare team which have to follow the bundle care is very important, and they have to be trained through appropriate education. There has to be appropriate methodology for implementing these bundles, and we have to track the compliance, of course. Anytime we feel that bundles are not appropriate and there is a change required, we can redesign the care processes. So these are some of the bundle care checklists. The checklists say that there should be 95% bundle compliance based on all or none marking. If all the bundle parameters are yes or ticked, then we follow it as 100% compliance. If any of them are not followed, it is 0. So this is for COTI care bundle, insertion and maintenance. This is for CLAPSI, insertion and maintenance, WAP, and SSI. So then comes the implementation. Implementation involves a lot of will building, lot of education and training, all or none approach, because the person has to understand that they have to follow all the bundle elements diligently. Only then they will be given 100% compliance. Otherwise, it will come back to 0. There has to be accountability. So whoever is following a bundle checklist has to sign it. We have to adjust the delivery system and address logistical concerns to make it easy to deliver the bundle as part of the system of care and workflow. So the process should be delivered very easily. Anywhere we find the complications, it always falls back. So we have to be very careful that it is being delivered easily to the patient. Okay, now as per WHO 2019 survey in 81 countries, we have seen that it was based on the all or none phenomena, and it was seen that 0% compliance for this bundle was observed in low income countries, which were part of these 81 countries. And in high income countries, the bundle compliance was 25.6% in primary facilities, 9% in secondary facilities, 19% in tertiary facilities. So we need to have more effective and sustainable practices. So how do we measure? Unless and until we measure and provide the feedback, we cannot have improvement in our processes. So measurement, as I have already discussed, it is all or none basis. And the accurate, consistent and ongoing measurement has to be there. So, and the feedback has to be given back to the caretakers on weekly or monthly basis as possible. Now, the outcome of the bundles is measured on the HAI, on the basis of HAI rates. So anytime you feel that the HAI rate of a particular unit is decreasing, it means that you have improvement in the care. So COTI, CLEPSI, VAP, these are being calculated as it is given on the screen. Now, challenges with the low and middle income countries, we have increased workload, we have high bed occupancy, we have scarcity of dedicated and trained staff. So this is why we have challenges in implementing bundled compliances and bundled care to our patients. There are issues with availability of supplies. Sometimes we don't get enough supplies to practice the bundled care. Inadequate hygiene and sanitation. So when the above practices are there, when the above scarcity is there, we see that it leads to inadequate hygiene and sanitation. Inadequate IPC education and training, we don't have good educators. So the first thing, that education is an important thing. When you design a bundle, you have to first educate the staff how to implement it, and then you have to measure it. So when your education part is missing somewhere, definitely you cannot have good results. IPC guidelines, it is the most important thing. If the guidelines are available, only you can think of implementing. So way forward is we have to have increased funding, which is dedicated to infection prevention and control programs. Accreditation audits are a must because they are promoters of bundle care compliances. Improve HAI surveillance. The more you measure, the better you can perform. Measure effectiveness of IPC program again by capturing the HAI rates. Leadership involvement and support. Without leadership support, we are not able to move a step ahead in improving our compliance. And accountability along with responsibility. So that is all that we had for the session. And thanks all for patient listening.
So, anybody have any questions regarding all these things? So, ma'am can answer. Hello, everyone. I'm audible to you?
Yes.
So, किसी को कुछ questions है तो पूछ सकते हैं regarding ये critical जो हमारा topic था जिस पे webinar हुआ है. अगर कोई question है, कोई doubt है तो कोई भी पूछ सकता है.
I had a doubt, ma'am.
Yeah, please tell me. Yeah. So, just a minute. So, voice.
So, we use a transparent tegadum for the central line dressing. But what we face is like when patient has a beard, the dressing doesn't stay for at least 2 days also. Where our protocol in the hospital says for 7 days. So like
Can you
just
part
to
the question? Yeah, please, ma'am. So,
Usually the transparent dressings stay for 7 days, but in your case, maybe there is a lot of sweat. So you have to maintain that control, maintain the temperature, and that is how you can control things. And maybe the quality of Tegaderm dressing that you are using has a compromising issue.
the same
Maybe you can check a different brand.
been used with the other patients, but mostly what we see is like in our surgical patients only we find this. Yes, that is true. As you said, that sweating is an issue, but the brand is used the same for rest of our patients also.
And all of them are doing fine.
Yes, we have only like in our cardiac patients we are facing this a lot.
Okay. So maybe sweating is because all other patients are doing fine, then I don't think it is of any concern. I mean, you have to find out the cause among the unit itself. What is going wrong in your cardiac setting, which is not in all other wards.
Thank you, ma'am.
Or if there is any patient-related factor.
Thank you, ma'am.
Okay.
A strong company.
Yeah. Anybody have any question?
International
Yes, ma'am.
Yeah, please tell me.
For how much time we use venti circuit?
Ventilator circuit. Have you seen your policy? Do you have infection control policies in your hospital? म्यूट हो गया नहीं क्वेश्चन जो पूछ रहा है
सैंपल और एक हम सेंटर लाइन के बीच वाला सैंपल लेना। तो जब हम सेंटर लाइन के बीच वाला सैंपल लेते हैं तो उसमें 10 सीसी हमने जब सैंपल विड्रॉ कर लेते हैं तो उसके बाद हम 5 सीसी से स्प्राइड सैंपल ले लेना सर्जिकल ग्लव्स वेयर करके। जो हमने पहले सैंपल निकाला हुआ है 10 ml निकाला कि वो दोबारा हम डाल नहीं सकते, डेट इज सोर्स ऑफ इन्फेक्शन। नो मैम।
आपने 10 सीसी सैंपल किसी सिरिंज से ड्रॉ किया है?
या सर्जिकल सिरिंज से हमने विड्रॉ कर लिया, फिर उसके बाद हमने 5 सीसी जो सैंपल चेक करने के लिए भेजा है।
हाँ 5 सीसी सैंपल कहाँ भेजा है चेक करने के लिए?
सैंपल जो हमने लिया है ना 5 सीसी
आपने ब्लड कल्चर बॉटल में डालना होगा ना सैंपल।
हाँ कल्चर वाले बोतल में हम डाल के भेज देंगे। जो 10 सीसी हमने विड्रॉ किया वो तो डिस्कार्ड कर देंगे ना।
क्यों डिस्कार्ड कर देंगे? 10 सीसी तो डाल रहे हो आप कल्चर बॉटल में।
नो जैसे हमने सैंपल लेना है सेंटर लाइन के बीच में, सेंटर लाइन से सैंपल लेना है तो पहले हम 10 सीसी विड्रॉ करते हैं उसके बाद 5 लेते हैं ना।
हाँ तो आपने सेंट्रल लाइन में जो के लिए जो सैंपल लेना है उस सैंपल को आपको क्या करना है कि इट शुड नॉट हैव एनी कंटामिनेशन। उस केस में आप प्रैक्टिस कर सकते हो, ठीक है, जैसे आपका वो मिड स्ट्रीम सैंपल आ जाए और आप बट एक्चुअली ब्लड कल्चर बॉटल में 8 to 10 ml सैंपल जाता है पेशेंट।
ठीक है मैम। और दूसरा मेरा ये क्वेश्चन। हेलो मैम।
हाँ जी
ऑपोजिट आर्म से लेना है वो भी उसी के साथ
प्लीज सब वन बाय वन क्वेश्चन करेंगे तो मैम कैन आंसर इजीली, है ना। बाकी सबका वॉइस मिल रहा है सो प्लीज अपने टर्न का वेट करिए। सो लेट हिम स्पीक। ओके सो प्लीज नेक्स्ट क्वेश्चन किसका था आप बोलिए।
Yes, ma'am. I have one question.
Okay, Rita Dhanal, yes, please tell me.
Yes, ma'am. A patient suffering for a coma, then how many days take a time catheter in use condom catheter?
Which catheter you are talking
Hello.
about?
Condom catheter, ma'am.
Condom catheter.
Rita, you are getting our voice?
Ma'am, hello.
हाँ जी।
Yes, ma'am. मैम अगर पेशेंट कोमा में है तो वो तो बता नहीं सकता। अगर पेशेंट कोमा में है सपोज आपने अभी कैथेटर बोला था तो उस पेशेंट।
रीता आपकी एक्चुअली आवाज क्लियर नहीं आ रही है। आपका शायद नेटवर्क जा रहा है तो कुछ और समझ में नहीं आ रहा आप क्या पूछ रहे हो।
आप चैट बॉक्स में क्वेश्चन डाल दो रीटा, वी विल एक्सप्लेन।
ओके मैम, आई विल डू इट नाउ।
या एनीबॉडी हैव क्वेश्चन?
मैम
yeah, it's Divya, right?
Yes.
Yes, Divya, please your question.
In our organization, for the central line, we are using autoclaved SMS sheets. But then to secure it, we use micropore. So just to know, like each and every time when you handle the central line, we need to each and every time we need to stick this micropore. So is there any other best practices which is being followed so that it can, I mean, we can also like use those guidelines to do that?
See, for cost effectiveness, maybe the micropore only has to be used, but then patient sweats, so it comes off. So securement के लिए other options that we have are costly. Yes, companies are giving the options, but they are expensive. You can
because like end users always they are facing is like each and हर बार हमको बदलना पड़ता है, हर बार डालना पड़ता है, but then we are like, no, you have to use it because it is the best way.
Because it
We
is
had
cost effective for hospitals.
yes, yes,
And
ma'am.
so that's the only case.
Excuse me, ma'am.
Oh, thank you, ma'am.
So yeah, please.
हेलो
Yes, yes, it's Srishti
मैम
Pandey.
एक क्वेश्चन है कि जो चिटिल फॉर्सिप यूज करते हैं अपन वार्ड में, उसके लिए क्या गाइडलाइन है, मतलब रखने के लिए? जैसे कि स्टरलाइजेशन हो जाता है कि ऑटोक्लेव करके रखना चाहिए, तो वो 24 आवर्स तो मेंटेन नहीं रहता है। और जैसा कि हमारे यहाँ बोलते हैं कि साइडेक्स में रखो, तो क्या ये मतलब इस पे थोड़ा सा आप गाइड कर सकती हैं क्या कि साइडेक्स में रखना बेटर है क्या, या फिर और कुछ तरीके?
जस्ट
क्योंकि सेवलॉन तो टोटली अब बंद हो चुका है क्योंकि कंटामिनेटेड करता है ऑलरेडी वो। वो डिस्कस कर रही है। ये हमारा क्वेश्चन है ना, साइडेक्स क्या है?
hi, Sriti Pandey, right? See, this question is for sterilization and disinfection of instruments, so which we have not covered in today's topic. So maybe it can be addressed in our later sessions, which we will be covering cleaning, sterilization and disinfection of instruments. ठीक है, उसमें हम ऑन साइट डिसइंफेक्शन भी कवर करेंगे एंड द ऑटोक्लेविंग and ETO.
Okay, ma'am. Thank you.
Okay.
Okay, so anybody have any question?
मैम मैम एक मेरा और क्वेश्चन है कि जैसे
It's
कॉटी
Monica. Yes, Monica, please tell.
कॉटी के लिए है मेरा क्वेश्चन। जैसे पेशेंट के हमने 3 दिन या 4 दिन पेशेंट के कैथेटर डलता है, उसके बाद पेशेंट डिस्चार्ज हो जाता है, तो जब पेशेंट घर से आता है तो कभी कभी उसे कॉटी हो जाता है, पर हमने जो प्रेजेंटेशन प्रेजेंट करनी है ओनली आईपीडी जब पेशेंट एडमिशन रहता है 4 दिन उसके अंदर वाली प्रेजेंट करनी है, और जो बाहर से आता है उससे भी करना होता है।
देखिए, आपको एक चीज ध्यान देनी है कि पेशेंट डिस्चार्ज कब हुआ है। अगर पेशेंट आज डिस्चार्ज होके कल फिर से रीएडमिट हो रहा है एंड कैथेटर इज पेशेंट ऑलरेडी हैज कैथेटर, ठीक है, उस केस में आप उसको अपने कॉटी के अंडर ही लेंगे। बट यस, इफ देयर इज अ गैप ऑफ मोर देन 1 कैलेंडर डे, मतलब परसों पेशेंट आ रहा है, देन इट इज नॉट एसोसिएटेड टू योर फैसिलिटी। इट इज लाइक दैट।
ओके मैम, थैंक यू। मैम मेरा एक क्वेश्चन था। मैम जैसे एडल्ट में हम लोग यूरिन ये डालते हैं, फॉलीज डालते हैं, पीडियाट्रिक के लिए हम लोग क्या कर सकते हैं मैम? जैसे फीडिंग ट्यूब डालते हैं पीडियाट्रिक में, तो क्या हम उसमें ले सकते हैं हमारे इसमें स्टडी में?
पीडियाट्रिक में तो आप वैसे भी डायपर्स रखते हो ना
मैम? डाइपर्स जो बेबी प्री मेच्योर्ड है, उनके लिए फीडिंग ट्यूब डाला गया है। मतलब एक केस है हमारे हॉस्पिटल में जिसमें फीडिंग ट्यूब डाला गया है, तो क्या वो मेरी स्टडी में आएगा?
फीडिंग ट्यूब को आप कैथीटर कैसे कह सकते हो?
मैम इट इज यूज्ड फॉर नियोनेट्स।
ये मैम यूनिट्स।
Feeding tube is used for neonates as for feeding
No, ma'am.
requirements,
If
na?
they are not, like
No,
if they are
ma'am.
having
For
issues passing urine,
As a
feeding
urinary
tube-
catheter.
Yes, ma'am.
yes, ma'am.
Okay, see, I have not seen such a case, so maybe I have to do some research. Feeding tube as catheter, I don't know. But anything that is indwelling in a patient's body, that invasive device has to be either taken out as early as possible, or all the preventive measures have to be taken as we are doing for adults to prevent infections.
Ma'am, so NG tube is also an indwelling equipment. So why don't we count that?
We don't count NG tube. We only count the lines that I have told you. NG tube is not a part of that because it is entering the gastrointestinal area, right?
Okay, ma'am.
तो गैस्ट्रिक एरिया में आप कैसे माइक्रोब्स को ट्रैक कर पाओगे?
Okay, ma'am.
ठीक है? So it is only when it is entering the sterile areas or maybe where you are not expecting pathogens to be present. Okay.
Thank you, ma'am.
Okay, thank you for joining the webinar and special thanks to ma'am जिन्होंने अपना बहुत expensive time यहाँ पर आके दिया and give us such a good knowledge towards these things. So मैं आपको ये भी बताना चाहूंगी जैसे कि एस्ट्रॉन से जिससे भी आप कनेक्टेड है फॉर द काउंसलर सो आपको सारी डिटेल्स मिल जाएंगे रिगार्डिंग द कोर्सेज जो भी आपने इंक्वायर्ड किया है. सो ये वेबिनार हमारे मंथ में 2 टाइम्स हुआ करेंगे. सो हर जिसका आपको 10 डेज पहले ही आपको सारे ब्रॉशर्स मिल जाते हैं सो यू कैन ज्वाइन द कमिंग वेबिनार एज वेल एज. एंड जो एस्ट्रॉन इंस्टीट्यूट है वो एक्चुअली हम जो है 18 ईयर्स ओल्ड कंपनी जैसे मैंने बताया हमारे काफी सारे विजन्स हैं लाइक हम अभी हॉस्पिटल प्लानिंग में भी हैं डिजाइनिंग में भी हैं एक्रीडेशंस में भी हैं जैसे हम NABH एंड JCI भी कराते हैं हॉस्पिटल्स को साथ साथ हम अपना इसमें हॉस्पिटल प्लानिंग डिजाइनिंग में भी हैं. एंड जो हमारे सर्टिफिकेट प्रोग्राम्स हैं जो कि नर्सेज के लिए स्पेशलाइज्ड सर्टिफिकेट उनको जो मिलता है शी एंड ही विल बिकम द सर्टिफाइड नर्स एंड इट इज वैलिड लाइफ टाइम वैलिड है इंडिया के साथ से इंटरनेशनली भी एक्सेप्टेबल है. सो अगर इससे आगे आपको कोई भी कोर्स की अगर आपको डिटेल्स चाहिए सो अपने जो भी आपके कनेक्टेड काउंसलर हैं आप उनसे कांटेक्ट कर सकते हैं. ओके एंड आश्रम पे जाके भी आप मैसेज कर सकते हैं. सो होप thank you so much for your precious time to connect over the webinar. So we'll give you the next webinar very soon. Thank you so much. 22nd of June we have another webinar. So वो उसकी details आपको मिल जाएंगी. So
22nd.
Yeah, 22nd of June coming. Yeah, by June. Yes. Okay. So thank you so much. Have a great day. Yeah.